Thank you so much for having me again on the second TESS talk. It's really an honor to be speaking amongst such esteemed colleagues who have so much knowledge about aesthetic medicine in general, but especially TESS lift, you know. I really, really appreciate the opportunity. Full screen, but I'll just use it as is. Okay, so talking about the Rhino series today with TESS lift. So I just want to basically share my experience and what I feel about it. So this is basically all my own opinions and from things that I've learned from Dr. Kim himself as well. We've only had TESS lift in the country this year, so it's not something that's been around forever. But definitely it's become a massive part of my practice. So yeah, let's get started. So non-surgical rhinoplasties have become increasingly common over the past few years. As aesthetic medicine grows, so too do the options for non-invasive options for altering one's appearance. Although, as I tell all my patients, we cannot substitute surgery for non-invasive procedures. Obviously, the results with the surgical procedure is going to be a lot more dramatic. The fact is that the results that we are now achieving with non-invasive procedures are really comparable and much, much more affordable. So this is making plastic surgery a lot less common, especially in our country. I find a lot of plastic surgeons are now moving over to doing aesthetics as well, because they are getting such good results and people simply cannot afford to do full-on plastic surgery operations. This is obviously most notable in the realm of non-surgical rhinoplasties, where the advent of liquid rhinoplasties has become very, very popular. They've been advertised as quick and easy procedures with less risk. The use of fillers in the nose is now being performed worldwide by both trained and unfortunately untrained aesthetic professionals, which is not the best thing to happen. Social media is being flooded with before and afters of really notable transformations, sometimes unbelievable transformations of the nose. The problem is the patients who are consuming this advertising are often very unaware of the risks associated with fillers being used in the nose, such as vascular occlusion and migration of filler. This is why it's such a risk for me. So the vascular supply of the nose, we all know this is, I mean, the nose is a minefield, and the risk of putting potent. While I do not advocate against the use of filler in the nose, in fact, I actually use fillers in the nose from time to time in certain patients with certain indications who really do require it. Perhaps they have a simple little hump that just needs a little bit of filler. The fact is that every time I put a filler with a needle to the nose, I sweat. And that night, I have sleepless nights because I'm always worried about early and late vascular compromise. More recently, the use of threads in the nose has come to light as a successful and often for probably much safer option for non-surgical rhinoplasty. I feel much safer in the knowledge that when I put a thread in the nose, the risk of a vascular event is highly unlikely, and the fact that the thread is going to stay put and not going to migrate as filler could to give you a misshapen nasal tip or a widened nasal bridge later on. In my opinion, the use of threads in the nose rather than filler is actually an easier procedure. And I feel a lot more comfortable to perform it without. If you are comfortable in doing facial threads like the TESS soft you've now seen in the face, it's only one small leap to actually using threads in the nose, and you can start producing beautiful non-surgical rhinoplasties. So for me, the most important thing is that provided that the nasal threads are placed in the midline, obviously excepting the nasal alar thread, subdermally, and sterility is maintained at all times, very little can actually go wrong, which I love. Look, don't get me wrong, training is definitely essential, and everyone should have training before they start putting threads in the nose. This talk is not enough, but it definitely does. It's an easy procedure once you know how to do it. The TESS Rhino series is very similar in nature to the actual TESS soft used in the face, where it's a PDO thread, as Dr. Kim has mentioned, with helical or multidirectional cogs surrounded by a mesh. The cogs will grasp the subdermal tissue of the nose, whereas the mesh allows for tissue ingrowth and extreme amounts of collagen production, which is, in my opinion, is unparalleled to any PDO thread on the market. The fact that the tissue ingrowth occurs a few days post-procedure means that your thread is not going to migrate. So it stays put. So the shape of the nose that you have created is not going to change. So when your patient walks out, they're not going to come back a few weeks or a few months later with an altered shape as may be possible with fillers. The results also last up to 2 years or even more. So as I said, TESS is new to South Africa, so I haven't had patients at the 2-year mark, but I know from colleagues' experience that it really does give you a long-lasting result. Of course, any aesthetic procedure comes with risks. The aesthetic procedures comes with risks, and it must be mentioned that due to the nature of these threads and the tissue ingrowth, the risk of biofilm is increased, especially in the nose. You know, nostrils are already cleansed before introducing threads. This is a foreign body that will definitely cause a biofilm to form if the nose is not cleaned thoroughly. Okay, so I'm going to show you a picture now of how I drape every single patient to ensure that the sterility is maintained. I also I drape the patient after obviously thoroughly assessing the patient while sitting up to ensure that I meet all their done. So every single patient who gets either tested rhino or tested soft in the face gets draped this way. Okay, so the rhino series is comprised of 3 nose threads. So we have the nasal dorsum, ND, which is for dorsal augmentation of the nose, NC, which is for strut formation in the nasal columella, and NA, which is for narrowing of the nasal alveoli in a widened nose. Picture of some nasal anatomy. I always like to put anatomy in anything that I do. The nasal or ND nasal dorsum threads are the ones that I probably use most commonly. The positioning of the ND thread from the nasum to the nasal tip will succeed in defining the nasal bridge and resulting in a streamlined nasal dorsum with smoothing out of the irregularities or with any nasal bumps. So this is probably the most common thing that people ask for, is they've got a little ridge or a little bump and they want it to be smoothed out. The volumizing effect of these thick threads will definitely improve and streamline that nasal dorsum. The nasofrontal angle can also be corrected by positioning your positioning your thread at different points within the radix. So if a patient is a male, we want to achieve a nasofrontal angle of 130 degrees with slightly convex nasal dorsum. And in a female, we want a 134-degree nasofrontal angle with a slightly concave nasal dorsum. This is achievable with the ND thread. A drooping nasal tip, also a very common issue, especially as we age. I like to call it a witch's chin and a witch's nose. They sort of turn towards each other. So we can correct this with a combination of ND and NC threads. I always start with the ND thread first to pull back on the nasal tip. And then an NC will create a beautiful strut to elevate the tip and increase the forward projection of the nose, as well as widen the nasolabial angle, as Dr. Kim mentioned. Finally, a widened nose can definitely be narrowed with use of NA. The NA thread is placed from one side to the other, just subdermally inferior to the columella, and then a loop is created on either side to reinforce the thread. The procedure itself is really, really fast. And actually, it takes me a lot longer to prepare the patient and anesthetize them than it actually does to do the thread itself. Procedure itself, the steps that I follow: we clean the face, we mark the nasum, both the current nasum as well as the desired position of where we want the nasum to be based on the aesthetic goals we want to achieve. I mark the midline and the entry points. The entry point on the tip is not at the tip, but it's actually a few millimeters inferior to the nasal midline. For NA, we mark entry points on either side of the nasal alar, and then we drape, as I showed you. We then use anesthetics. So I use a 32 gauge needle for the entry points. I normally use Xylotox with adrenaline in the entry points, and then create an 18 gauge entry points, depending if I'm doing just ND/NC or NA as well. And then I use a cannula to anesthetize the entire nose so that I know that the patient is going to be comfortable during the procedure. Basically, so cannula is literally inserted all the way from the nasal tip up to the nasum, and I inject anterograde and retrograde with the local anesthetic. because a few droplets of anterograde local anesthetic goes a long way to ensuring that the tenderness of that cannula going up the dorsum is not as bad. I also then change position and go down all the way to the nasal spine with the cannula in order to anesthetize the nasal columella. And with nasal alar, anesthetize from one side to the other. Sometimes with multiple needle punctures or with a cannula, is actually nice to open up the plane so that it's easier to insert the thread.